we've been hearing about the refractive surgeries like LASIK, PRK, cataract surgeries. So let us talk about a common link among all these surgeries, that is dry eye. So a very good morning to everyone. I will be talking about DEWS 2, that is Dry Eye Workshop 2, what it gives us the new thing besides the DEWS 1. So basically DEWS 1 in 2005 defined dry eye in a very scientific way. So dry eye, they defined it as multifactorial disease, which means that it is a very complex functional disorder of ocular surface. Ocular surface means the whole of adnexia, which includes the lacrimal glands, meibomian glands, the tear film, the conjunctiva, the cornea. It is also defined as the loss of homeostasis. That means the balance between the body functions which are related to the chemical composition of the tissues and the body fluids. It causes ocular symptoms, and along with all the inflammation damage, it causes a tear film instability and the hyperosmolarity. So what is new in DEWS 2? So DEWS 2 basically adds a very prominent feature in this definition, that is neurosensory abnormalities. So when we see, this is a very common scenario which we come across in our clinic, that patient comes to us and they complain of pain. When we examine them on the slit lamp, we do not see any signs. So this pain without any stain is a major clinical concern for all of us. So let us understand why this pain is there in the dry eye patients. So when we talk about the pain, there are two types of pains. One is the nociceptive pain and the neuropathic pain. The nociceptive pain in general is because it is an acute pain. It causes because of the actual damage to the tissues and organs, and the nociceptors get stimulated. The neuropathic pain is there is a problem in the somatosensory system. So neuropathic pain is generally a chronic one, and many a times nociceptive pain over a period of time becomes chronic and gets converted into the neuropathic pain. As we know that we have a lot of these nociceptors in cornea, like mechanonociceptors, the polymodial nociceptors, as well as the cold thermoreceptors. All of them play a role in the nociceptive as well as the neuropathic pain. So let us understand what is the pathophysiology behind this pain. So we will go through one of the studies which was done at Narayana and Nethralaya, where all the clinical findings of the tear film and the dry eye were diagnosed. The confocal images were taken, tears were collected in the clinics and were sent to the laboratory, and in the lab the molecular analysis was done. So in this, the patients were given even the ocular surface OSDI score basically. The result of OSDI score, as we see here, is increased the discomfort level and the OSDI score levels in the dry eye patients compared to the controls. When we talk about the confocal images were taken and they were studied for the mature as well as the immature dendritic cells. They were also studied for the subbasal nervous plexus. The result for the confocal images were, we found that all the immature as well as the mature dendritic cells were increased in the dry eye patients. There were changes in the subbasal nervous plexus in their length, density, but they were not very predictive. When we talk about the molecular analysis of the tears, first let us go through the journey of the tear in the Narayana Nethralaya. Basically, the tears are collected in the clinic. They are sent in the lab by maintaining a cold chain. They are stored at -80 degrees centigrade, and later on, after centrifugation, they are studied by the lab people for the molecular analysis. So in this, what we saw is the pro-nociceptive factors like interleukin 1 beta, interleukin 17A, IF and G, the growth factors like VEGF-B and the neuropeptides like CGRP were increased in dry eye patients. At the same time, what we noticed was the anti-nociceptive factors like interleukin 2, 4 and 10, the growth factors like VEGF-A and the neuropeptides Y were decreased. So what basically happened over here is, in the dry eye patients, what we saw, on the confocal images, the dendritic cells, which were immature as well as mature, were increased, and the pro-nociceptive factors were increased, and at the same time, the anti-nociceptive factors were decreased, and this all causes the exaggerated nociceptive response in the eye. So to understand this, We'll go through this small video, which is an animated video, where it shows that when there is an imbalance between the pro-nociceptive factors and the anti-nociceptive factors, the pain-mediated channels get stimulated and it causes the depolarization of the nerves, which gives us the nociceptive pain. So normally the pro-nociceptive receptors are blocked by the anti-nociceptive factors. When anti-nociceptive factors are less, these are open and they cause activation of these pain-mediating channels. So this is one more thing which we see very commonly when patients tell us that they are very uncomfortable when they go out in a windy situation or when they sit under the fan or the AC blow is there. So basically here, what is, it's not playing? The video is not playing.
Just go back.
So basically what happens is all of the cornea has the back. Just play the video. The cornea has the cold thermoreceptors. So whenever the cornea gets it gets exposed to the wind or any kind of the chilly cold this thing, and it causes the evaporation of the tear film. Even in the evaporative dry eye disease, it causes the activation of these thermoreceptors, and it causes the activation of these thermoreceptors and depolarization of the nerves occur, which gives us the pain sensation. So this is again very important thing which we see in the dry eye, which is complained by a lot of our patients. So basically all this, I don't know what is happening. Okay, I'm going further. So basically it is very, very important to diagnose dry eye in our clinics because it has become a global problem. So we need to ask a lot of questions to diagnose these dry eye diseases. The DEWS actually gives us a list of questions which we need to ask. We need to ask about their discomfort. We need to ask about the systemic features like dry mouth, any swollen glands, the thyroid status, and we need to ask them even the triggering factors like smoking, whether there are any systemic medications, because a lot of systemic medications do cause dry eye. After that, we need to do, after the symptomatology and the questions, we need to do the tests which we commonly do in our clinics, like the T-bud, the hyperosmolarity. Nowadays, you do get the kits where you can actually measure the osmolarity of the tear film and the staining patterns and Schirmer's test. And we divide the dry eye into the evaporative and the aqueous deficient disease. So basically, after diagnosing the dry eye, we need to treat also. So basically, the dry eye disease treatment, the first thing is the lubricating drops. So do we have any perfect ideal lubricating drop? The answer is no. There is no perfect ideal lubricating drop, but most of the primary line treatment like CMC drops, HPMC drops do work very well. They do not have anything, everyone has its pros and cons, not a single drop is better than the other. The basic thing what we see, many people do give omega-3 and 6 fatty acids. So do they really help? DEWS says that there is no global consensus on the benefit of these omega-3 and 6 fatty acids. So I really don't think so that it really benefits in our dry eye patients. Yes, the role of vitamin D and B12, as we all know that vitamin D deficiency induces the inflammation and the whole cascade starts of the nociception. And vitamin B12 is again very, very important. The deficiency can cause the neuropathic pain. Again, we do have these smart lubricating drops and the anti-inflammatory drops, which do certainly help in the controlling the inflammation. So it depends whatever we want to use. We have different conditions where we can use these smart lubricating drops. But the acute condition, the main thing is initially you need to give the steroids to control the inflammation, and the cyclosporine out of all these things is my preferred choice. So what about the neuropathic pain? Many a times we do not see anything. What do we treat? So neuropathic pain is a very complex thing to treat. It is not only an ophthalmologist which can treat. So besides being what we discuss about the lubricating drops, the smart lubricating drops, the vitamin D, B12, what we need to do, even if the pain does not consider and does not come down, there are a lot of papers which have shown that the autologous serum does help in reducing the neuropathic pain, but unfortunately the moment you stop the autologous serum drops, the pain comes back again. There are a lot of systemic therapies you can do if the pain is really bothering the patient, like GABAergic drugs or the serotonin uptake inhibitor or tricyclic antidepressants can be used in all these patients. Again, there are a lot of complementary treatments and the alternative treatments like acupuncture and scrambler therapy. Maybe the meditation would help. So managing dry eye pain and the neuropathic pain is not only an ophthalmologist's job, but we need actually a combined multi-speciality approach with the ophthalmologist, neurologist, and a psychiatrist. Thank you so much.